when we look at the advances in the treatment of metastatic colorectal cancer over the last years, there are several things that actually happened. First of all, we have more drugs available for treatment. We went beyond chemotherapy agents, irinotecan, oxaliplatin, 5-FU, to incorporate biologic agents routinely in our treatment. We got new agents like regorafenib and TAS-102. So the more agents we have, the more treatment options we have for our patients, the longer we can keep them alive. Secondly, we saw the emergence of molecular profiling as one of the standard features in the management of patients. So we routinely identify patients with MSI-high, mismatch repair deficient cancers. We check for BRAF and RAS mutation to really select patients for specific treatments. Newly on the horizon is HER2, which is another marker which you can use to target, and use HER2 targeting agents like trastuzumab, pertuzumab, breast cancer agents, more or less. So there is this emergence of new treatment options and refinement of treatments based on molecular profiling of patients. And both has enhanced our treatment options and outcomes for patients. By utilizing all these different treatment options, we've seen some groups of patients that are candidates for immunotherapy, for instance, having extremely long survivals in metastatic colorectal cancer now, which we don't even know exactly how to capture because we've just started using these agents. Those patients might have years and years of overall survival on immunotherapy, the patients with mismatch repair deficient cancers, which unfortunately only make up about 5% of patients with metastatic disease. Otherwise, we've seen movement of overall survival in clinical trials from the era before biologic agents, about 20 months median survival, to now routinely approaching 3 years in median overall survival with the incorporation of biologics and sequential use of these agents.
Over the last couple of decades, a number of agents have become available to our patients, and that certainly has complicated in a good way the way we think about sequence. Time after time, what we've been seeing and what we've been observing and the studies have been showing is that exposure to multiple lines of therapy, effective therapies, seems to continue to stretch the survival of patients. And now, at least in the KRAS or the RAS wild type patients, we're talking about survival that's close to 40 months. We're getting close to the 4 years mark at the median. Which essentially means a lot of patients now are surviving beyond the 5 years, attaining even 10 years with metastatic disease. So that's important to keep in mind. And if we look at the whole landscape of studies that have led to this improvement, each one of them has contributed a little bit. The first line is usually the major contributor, although again, it's a relatively small delta. But then you look at every line of therapy, there's about a couple of month improvement, and all this has taken us from 5-FU alone, where survival was about a year or a little bit less, to close to 3 to 4 years. When we think about choosing and sequencing therapies, there's still quite a bit for us to learn. We think that there are at least multiple options that are available. We're not very clear about how to choose best. We have ideas about, if we have and we should have at least RAS, BRAF, HER2, MSI, and one could argue even NTRK fusions available from the get-go, because they help us somewhat in the long-term planning as well as the short-term, and the sidedness of the tumor. Then age comes in place, whether resectable or not, and then patient's preferences, right versus left. So a lot of things essentially enter into that equation and the discussion with the patient. So there are a number of guidances about how to consider doing it. There are still some questions that are pending. It has become clear to us that regardless of RAS status, meaning a RAS wild type, BRAF wild type tumor on the right, does not seem to benefit from EGFR inhibitors. So we know that in addition to the biomarker, the sidedness matters on this side. On the left side, it's a little bit different. I know we're talking about the first line. Is it EGFR or VEGF inhibition? There are trends that may favor a little bit more the EGFR inhibitors, but that does come also at a added level of toxicities and perhaps even a little dent into the quality of life. So we have to think about all these things as we choose. It's just not a number, but a number of things that go into the equation. So I think overall we have a level of comfort about what makes sense and what may not, but there is no very rigid line. This is what you get first line, second line, third line, depending on this number or this number. There's essentially a lot of things that go into this equation and in the discussion between the patient and the physician.